A very good afternoon to all of you. I am Dr. Sudhir Kumar Srivastava, Professor and Head of the Department of Orthopedic, St. G.S. Medical College and KEM Hospital. It gives me great pleasure to welcome you all for the fourth webinar of the PACE series. The initiative PACE PG Academy for Continuous Excellence is designed by Indian Orthopedic Association in collaboration with Janssen India and Insignia Learning to enable you to strengthen your orthopedic fundamentals, thereby helping you in your academics. Today's webinar is divided into two sessions. The first session will be on tuberculosis of spine, which will be taken by me, and the second session will be on pain management in spinal conditions, which will be taken by Dr. Ashok Kumar Saxena, Professor and Head of the Department of Anesthesia, University of Delhi. After this webinar, you will have to attempt a self-assessment which will make you eligible for certification from IOA and AAOS. Thank you and all the best.
My best wishes to the young budding orthopedicians who are attending this webinar.
Tuberculosis of spine is actually a very rampant disease in our country and also in other Asian countries. It is a chronic infection of spinal column caused by Mycobacterium tuberculosis. It can lead to severe deformity in the spinal column and leading to neurological deficit. This topic is very vast. To make it more productive, I will be talking on the three subtypes and three categories to describe this. One, and the first will be changing scenario in the management of the core strength of management strategies and decision making in specific situations. As far as the etiology goes, the causative organism Mycobacterium tuberculosis is as old as human evolution itself. If you go through Ramayana, there is a mention of this kyphotic deformity of Kubudi, and you can imagine the age of this disease itself. In our mythology and ancient science, it used to be called a Chaya Roga, means disease of destruction. The spinal column is secondly involved, being a part of osteoarticular system. In tuberculosis, the management guidelines have been changing. It has evolved gradually. In the pre-drug era, the TB bacilli, it had upper edge, and the human being mainly dependent on immunity, and we were dependent on the sanatorium. Then there was a discovery of anti-tubercular drug, and there was wide use of drug, and there was effective control of the growth of bacilli, and we moved from the era of plaster jacket to internal fixation. Then this anti-tubercular drug started being used wrongly, without any proper dose, weight of the patient, and there was a casual attitude, and this has led to the metamorphosis of the bacteria. Bacteria has mutated and there is an emergence of resistant strains, and nowadays we find there is a poor response and there is a failure of treatment. We have nowadays false feeling of defense and security, and we boost ourselves that now we have bedaquiline and pretomanid with us, and we have good surgical strategy and implant. But remember, even the bacteria is playing. The TB bacilli, there is a mutation in its gene, and now we have a strain of MDR, XDR, and even TDR. And this is because of improper medical management and decision making. Children are getting primarily infected with MDR bacilli. Now, about the pathogenesis, the TB bacilli, it first goes into lymph node, lungs and viscera, and through hematogenous spread, it goes to the spinal column. The spread may be arterial, venous or lymphatic. From lymph node, it can involve the cervical area and craniovertebral junction. From the lung, it can go to the dorsal spine, and from the viscera, it can go to the lumbar and lumbosacral area. Though we divide tuberculosis of spinal column in four varieties: paradiscal, central, anterior and posterior, but bacteria doesn't follow this classification, and you can have a global involvement. You can have a significant destruction of practically almost the each area of the spinal column. I will just give you some example. This is the first case. This young lady, she came with paraplegia. She had significant chest involvement. There was a pathological fracture of the rib, and there was chest wall abscess. If you see the MRI, there is a significant posterior compression, and there is a epidural cuff in that area. There was also a skip lesion in the different areas of the spine. The posterior decompression and stabilization was done, and lady started improving. This is the second case. This was actually treated with us. We had done the culture, and the culture came positive, and it was sensitive to bacilli. 4 months back, when we saw this lady, the lesion was though healing, but she later on, just after few weeks, came with a huge abscess. And you can see in MRI, it is almost coming to the subcutaneous level. And when the culture was resent, it found to be MDR. And then we started second line drug. The third case, she was a young girl of 11 years. She presented with the neurological deficit and backing out of the implant. Now here you can see the CT where the implant has come out. There is hardly any purchase over the proximal segment. We had to change it, and we did the hybrid fixation with reconstruction using the sublinear wire proximally. So proper rod contouring and anterior reconstruction is extremely important when you want to reconstruct the column, because if the anterior column is not reconstructed, in that case the implant is going to give way. Now this is another lady who had significant involvement of the spinal column. She came with paraparesis. There was a pulmonary cox. The hip joint was involved, and you can see in the spinal column practically the dorsal and lumbar and lumbosacral junction is involved. When the biopsy was done, the culture came out to be XDR. XDR means resistant to INH and rifampicin, any fluoroquinolone, and one of 3 injectable second line drug. So here we had to start the medication according to the sensitivity. The natural history looks pretty simple. There is a spinal tuberculosis, there will be infection and inflammation, there are initial symptoms and signs, you put the patient on antitubercular drug, and ultimately it leads to bony ankylosis. Sometimes the late sequelae are in the form of facetal subluxation, dislocation, which ultimately leads to significant deformity and late onset deficit. Now this is the lady, she came with significant deformity, and she did not come for a deformity correction. Her main complaint was a fresh discharge from the old sinus. What does it indicate? It indicates that still the lesion is not healed. The bacteria is still active, and we'll have to take a note of it. In pediatric age group, this TB bacilli is causing significant problem, and this age group is vulnerable. If you see the children who are below 9 years of age, the disc has its blood supply. The bacilli affects body as well as disc. The body are cartilaginous, and the patient has weaker immunity. There is extensive vertebral destruction, exuberant abscess formation, and the multiple segment involvement of the spinal column is going to be there. The posterior element are supple, it is elastic, so there is a chances of significant kyphosis. There may be skip lesion, there may be epidural lesion. Why pediatric spine is different? Because the vertebral bodies are cartilaginous, vulnerable to rapid destruction. There is a major defect in anterior column, and which leads to deformity. Being a flexible spine, it is susceptible to instability and greater deformity. Deformity in children, even after healing, continues to grow until skeletal maturity. So the periodic follow-up till skeletal maturity is important. Among all spinal TB cases, the incidence of pediatric spinal tuberculosis is almost 26 to 58% in Asian population. Now, I will be presenting this second case. She was a young lady. She came with the pain in low back and she was unable to sit without support. There was numbness in lower lip. There was no motor deficit. Now if you see the plain X-ray and MRI and CT of this lady, almost whole of the lumbar spine is destroyed. There is no lumbar spine. You can see directly D12 and S1 is visible. Now this lady, she was operated twice in her childhood. There was implant failure and it was taken out. So here there is a failure of column. So even after knowing the natural history, still there are setbacks during the treatment and we should be aware about that. So this is an unresolved issue. More and more understanding is evolving. Since many years there has been literature and our understanding is improving gradually. If you go through the literature, there have been multiple publications. It has started in 1894 by Minard. Then we have Hodgson Stock, significant contribution in literature, and which has started in 1960. Then we had our own Indian consultant who have published. Dr. S.M. Tuli, he came with the middle path regime and he published in 1975. Then Dr. Rajsekharan, he contributed a lot about the pediatric tuberculosis. Dr. Anil Kumar Jain, he has multiple publications in TB spine. And very recently you can see 2008 there is again repeat publication from Dr. M.S. Moon. So there is a changing scenario and evolving understanding. Decision making has to evolve scientifically, practically and rationally. What is the pathogenesis of kyphosis? So there is a central destruction, there is a destruction in the apical area, there is a collapsing anterior column, so the all bodies are buried in the graveyard. In fact, you can count remaining posterior element. So there is a failing tensile surface. It leads to facetal disruption, subluxation and dislocation, and patient carries a severe deformity. There is a phenomenon of addition where there is an addition of proximal and distal vertebrae to the kyphosis. So kyphotic deformity is a sequelae of anterior destruction and biomechanical collapse. The deformity may be in the different form. It may be knuckle, angular or gibbous. The patient presentation with the deformity may be of two types. There may be a wet lesion or maybe a heel lesion. Usually wet lesion after healing gets converted into heel lesion. Wet lesion, it is easy to correct because it is supple, and heel lesion, it is rigid and correction is demanding. What is the ultimate fate of the resultant imbalance? It depends on extent of deficient corpus, that is the body, the ability of the proximal and distal healthy osseous tissue to come closer and form bony ankylosis, the differential growth of posterior elements in growing age. What is the concept of focus centralis? It triggers the deformity. The triggering of the deformity is because of the destroyed apex, and we say it is a focus centralis. So the destroyed apex goes deeper and deeper in the deformity. The vertical axis, which is a line of gravity, it pushes the proximal and distal segment and they try to come closer by. There is a progression of kyphotic curve. So initially it is lazy C, then it becomes deeper C and further deeper C. What is the true apex of kyphosis? It is the important factor. It determines the end vertebrae of the apex. Here you can see this is the proximal most body and lower down is the distal most body, and which starts angulating distally and proximally respectively, coming closer to the apex, and there is a further tilt, and a time comes the anterior surface of the proximal vertebra and the distal vertebra becomes parallel, and we have very severe deformity, which is most of the time more than 100 degree. The severity of the collapse during active phase depend on the severity of the vertebral destruction, level of the lesion, age of the patient. It may be of three types: thoracic or thoracolumbar area, where the deformity is more because the thoracic area is kyphotic. 30° for each body loss is contributed in this deformity. Children less than 10 years, more deformity is there because they have short vertebral bodies, weak posterior structure, and there is an adolescent growth spurt. All these contribute to the severe deformity. In lumbar area, there is a less collapse because of the lordotic curvature, there is a large intervertebral disc, and there is a sagittal orientation of the facets. Rajsekharan has described very nicely in his paper in Urospine about this. The post-tubercular healed kyphosis in children, the kyphosis increases even after healing because of the variable progression during growth, dynamic deformity. This has been published by Rajsekharan in JBJS volume 83 in September 2001. It is a very illustrative presentation, you can go through it. So he divided into three types. Type 1, there is a deterioration even after healing. Type 2, the progression had a decrease in deformity. And sometimes there is a lag period which he has given a subtype of type 2B. And in type 3, no major change during growth. What are the clinical features? There may be constitutional symptom in the form of evening rise of temperature, loss of appetite or loss of weight, and it is seen in almost 60% of the patient. But this has not become now important finding to say that this is not tuberculosis. We are finding many patients who are not having these constitutional symptoms, and we must be aware about that. Patient might have pain, muscle spasm, restricted movement, there may be night cries, and which is pathognomic of development of spinal instability. There may be guarded walking, and patient takes all these postures to give some stability to the spine. There may be abscesses in different area of the spine. These abscesses are known as cold abscess because it doesn't have any signs of inflammation. If the abscess is very large, it can lead to mechanical compression, and patient might complain in the form of dysphagia and dyspnea. And if the abscess is superficial, it may be very significant. It might stretch the skin, and skin can give way, and there may be post-discharge and sinus formation. Neurological deficit may be in the form of upper motor neuron or lower motor neuron, or it may be a mixed variety depending upon the area which is involved. In the early deficit, usually the cause is inflammation or edema. There may be compression because of pus, convulsion tissue or sequestrum, or it may be because of instability. In late deficit, usually it is because of the internal gibbous, instability or chronic ischemia. The investigation which are very important, the first and most important is plain X-ray. Nowadays there is a habit of just going and seeing the MRI. Patient also comes with the MRI, but that is not a right way of dealing this disease. One must ask for plain X-ray, which is very important. It doesn't show the exaggerated intensity changes. MRI is very sensitive, it picks up even edema. So never say that the whole area is diseased. It may be just an edema in proximal and distal area. It shows the extent of neural compression. We may be able to find the skip lesion nicely. Additional coronal cut, it gives three-dimensional idea about the involvement of the column. CT gives better picture of the extent of bony destruction, and it is important investigation in the area like C1, C2. The biopsy is important. It should be done fluoroscopy guided, or sometime it might be asked even for the CT guided biopsy. The material should be sent for culture and sensitivity and histopathological examination. The biopsy is the most important investigation in tuberculosis. It should be well planned after going through clinical findings and radiological investigation. It decides the most possible yielding site, by seeing the MRI, you can know this is the area which is looking to be very active, and you should try to target that area. The long-standing cold abscesses may not yield organism. So in this case, if you take out the pus, you might not find the bacilli in that. Rather, you should go to the area where it is a diseased part, and that is the lumbar vertebrae, and one should try to take the material from lumbar vertebrae. Now, in a case where there is a paradiscal lesion, one should try to hit the pedicle which is near to the disc, like in D8, D9, D9 pedicular biopsy should be done, as it is quite visible clearly in this MRI. Target the junctional zone or possible active zone. Adequate samples should be taken, and J needle biopsy is important because it gives a core biopsy and the material which you get is sufficient. Tissue culture is equally important. Samples should be sent for histopathology. The proper collection, preservation and early transportation, microscopic examination and inoculation is extremely important. You take all the pain to take out the material, and if it is not transported properly, in that case your whole exercise is futile. Now tumor becomes one of the important differential diagnosis. Now see, these are the two MRIs. One side, on the left side it is of tuberculosis, on the right side tumor, and it is histopathologically proven, almost looking same. So in spinal tuberculosis, the critical evaluation is important. First, you should question yourself whether you are treating a TB case or something else. What is the immunity of this patient? You should have a suspicion if the patient is not responding. Which area is involved? Junctional area behaves differently. Whether there is any associated instability, what is the neurology of this patient, and what is going to be the compliance of this patient for taking the treatment. This is extremely important. There are defaulters, there are many defaulters, and we have got the problem of MDR because of that. The bacteria which we are dealing is MDR, or it is a sensitive bacilli. Now we have modalities of different investigation. We can have the microscopic investigation in the form of fluorescent and LED. We can have culture in the form of TB, MGIT or BACTEC. And we have now gene amplification, PCR and gene expert. The foundation of correct anti-tubercular chemotherapy is dose related. So the medication should be given according to the weight of the patient. Isoniazid should be given 5 mg per kg body weight, rifampicin 10 mg per kg body weight, ethambutol 15 mg per kg body weight, and paragenamide 25 mg per kg body weight. There are very self-tested regime. You might be knowing there is a fashion of writing AKT4. Now if you see, these two patients are different. The left side is this patient is a huge patient, 112 kg. On the right side is almost cachexy. The same medicine cannot be prescribed to both of them. So it is important to take the weight of the patient and accordingly write the dose of that particular medication. So if you see, if the patient is 45 kg, 60 kg and 53 kg, which is written on the right side, these medications are not going to be helpful because it is inadequate. Nowadays usually we use HRJD and streptomycin is not being used because there is a primary resistance in our country almost 30%. Do not use streptomycin as interchangeable with the ethambutol unless culture shows there is a susceptibility to streptomycin. What about the local care? If patient has significant pain, there is a spasm and suspicion of instability, bed rest should be advised to the patient. So the AKT rest and analgesics usually takes care of this acute pain and spasm. Later on, one can start mobilization with properly fitting brace. In pediatric age group, usually brace and plaster jacket are well tolerated. One must monitor clinical radiological improvement in these cases. Be watchful if you find the lesion is atypical, like the ballooning of the cortex. Patient is not responding clinically and radiologically. There is a progressive destruction. There is the appearance of fresh lesion even with AKT. So you can have a scene when the bacteria is sensitive. Another situation, there is a MDR-TV. It means there is a resistance to both INH and rifampicin, and globally it is almost 3%. It may be XDR, that means MDR-TV with resistance to at least one second-line aminoglycoside and any one quinolone. And there may be some strain which is TDR, that is a total drug resistance. The drug resistance in India, in different groups of anti-tubercular drug, the primary line itself, it has started showing significant resistance. The INH, 16% in previously untreated patients, 46% in previously treated patients. Rifampicin, almost 23 to 34% in previously treated patients. The prevalence of MDR-TB in newly diagnosed patients is almost 3.4%. The diagnosis of MDR-TB, the LJ culture where you get 12 to 16 week time to get the sensitivity. In modern method of culture, backtech is important, MGIT gold is gold standard. Sensitivity results are available in 3 to 6 weeks. Now we have molecular methods of rapid TB sensitivity. Gene expert, you can diagnose TB and detection of rifampicin resistance in almost 4 hours. The line probe assay, detection of resistance to rifampicin, INH, ethambutol, quinolones and aminoglycoside in 24 to 48 hours. Now as regard to resistant TB, never add single drug to a failing regime. Now just adding Ciplox is a defensive prescription. The intermittent therapy should never be used in this. If sensitivity is available, have a regime with 5 sensitive drugs. Avoid starting second line AKT empirically. This is not right. If starting second line empirically, since you did not get anything, add at least 3 drugs never used before, at least 2 bactericidal. One of these drugs has to be injectable. 5 drugs are to be given for at least 6 to 9 months. Continue treatment with at least 3 sensitive drugs. Total duration of treatment should be minimum of 2 years. We know that tuberculosis is a medical disease and it remains a medical disease if you use the sensitive drugs. There is an in vivo war inside the body between body immunity and TB bacilli, and we support the immunity along with administration of anti-tubercular drug. It leads to progressive destruction in the form of collapse of the column. There may be neural compression, and as a surgeon we have to treat the sequelae. What is the role of surgery? Surgery usually for decompression and reconstruction if we are going to decompress for neural compression. There may be instability, for that we require to fix and fuse. There may be deformity and we might have to correct the deformity. Now this is an example case where there is a D9-10 COX, and if you see the epidural cuff, it has gone till D8. So how much to decompress? You can see these 2 yellow spots. Are we going to decompress this much? Can we save remnant of D9 and D10? So how to decide? How to decide that we can save this segment? What about the viability of that segment? Is it going to be a poor bet? Is there any criteria to retain or remove? So for this we started taking coronal cuts in MRI and CT. The coronal cuts, in addition to sagittal and axial cuts, it gives 3D dimension of the lesion. Now in left side you can see the disc space is violated proximally, and on the right side the end plates are actually quite nice and it can be accepted. Another thing about the deformity. Now there is the shaft deformity, and here this component is purely because of tilt. As soon as you instrument behind, then it gets corrected and you need not exercise this body. Now, decision making in TB spine. So you can have situations like spondylodiscitis without neurological deficit. What is the indication of surgery? Spondylodiscitis with neurological deficit, which may be in the form of without kyphosis or it may be with kyphosis. What surgery you are going to do, what approach you are going to use, and when are you planning to go anterior. In CVJ, usually the instability is the cause of deficit, where the posterior fixation is important and it is required most of the time. In cervical spine, one can do anterior decompression and fixation, or one can choose posterior fixation and then anterior reconstruction. In dorsal spine, the costotransversectomy is usually done to drain the abscess. Earlier people used to do anterolateral decompression. Nowadays it can be only done anterior decompression and reconstruction, or everything can be done from posterior. All from posterior can be done. Posterior decompression, instrumentation, and even the reconstruction can be done. In lumbar spine, posterior fixation, then anterior reconstruction can be tried, or even in lumbar spine, all anterior or all posterior surgery can be done. If patient has significant destruction, even if he is not having neurological deficit, it should be operated and it should be reconstruction because there is a significant anterior collapse. This is another case which can see there is a significant involvement of the column and there is a translation. So even if the patient is not having neurological deficit, one should try to operate and stabilize this column. If there is eccentric collapse, it is bound to fail, and in this case also one should try to stabilize the column and reconstruct and fuse this area. TB spine in junctional area behaves differently. So initially if patient is not having deficit, but if there is a progressive destruction, you have to intervene early, because later on the reconstruction will be very difficult and you have to have fixation significantly proximally and distally. Again, in craniovertebral area, if there is a significant bony destruction, even though patient is not having neurological deficit, you must stabilize it and try to reconstruct the column. In AAD, where there is a significant instability, you can see that there is significant loss of biomechanical alignment, and in such situation we have to stabilize this patient. CV junction, again, it can be treated with different ways. You can do the transarticular fixation if you are able to align it properly. You have to do the separate C1 C2 fixation if you are not able to align it preoperatively, but the main purpose is fusion and fixation in a aligned position. Now the pediatric spine, it behaves differently, and you should be aware about the spine at risk sign, which has been well described by Dr. Rajshekharan. So if you find there is a facetal disruption, posterior retropulsion, lateral translation or toppling, you must intervene early even if patient is not having any neurological deficit. The indication of surgery in children are usually if there is a significant bony loss, if the area is junctional area, if there is presence of spine at risk sign, there is a dense neurological deficit. If patient has neurological deficit, assess the factor, what is the cause of it. Is there a mechanical compression, is there a neural edema, if there is associated instability, or there was a chance of vascular insult. Assess the severity of the deficit. If there is a grade 3 or grade 4 power, but there is a concentric collapse and neural compression, you can try bed rest, AKT and steroid can be used. But if the deficit is dense, there is a bladder bone involvement, there is a circumferential tight compression, there is an unacceptable kyphosis, there is a translation and instability, one must intervene early. If patient has neurological deficit, this may be with kyphosis or without kyphosis. If without kyphosis, treat as per protocol for deficit patient. With kyphosis, it may be wet lesion or healed lesion. Wet lesion, it may be single level with mild kyphosis and no translation. Treat as other case of neurological deficit. If there is a significant kyphosis and translation, there is a golden time to correct it and one must do it. Heel lesion, it is usually because of late onset and there is an internal gibbous formation. One has to decompress it. When you are planning correction, always do the column shortening procedure and reconstruct the column. One example, no kyphosis, treat like other case of neurological deficit. AKT rest, if doesn't improve, do the surgical intervention. Wet lesion with kyphosis, like this case, the golden time to correct it and you must correct this deformity. Very classical lesion of the dorsal spine, there is a translation, angulation, circumferential compression. So usually it can be done nicely from behind, or one can use an approach where it can be accessed both posteriorly and anteriorly, and I usually use the versatile approach. You can go through this approach, we have published in Asian Spine Journal. One can have a long segment cord compression in a case where the whole lesion is to be excised, and it can be done by combined anterior and posterior procedure. One can do everything from posterolateral approach, and in this lesion we have excised the two bodies and it has been reconstructed with the arms cage. If it is paradiscal with deficit, we can decompress it and we can reconstruct it, and here rectangular cage has been used. When to go anterior? In cervical spine, the anterior decompression and reconstruction is done. Reconstruction of extensive cervicodorsal and lumbosacral junction lesion, again you have to go anterior, and for long lumbar reconstruction anterior surgery is required. So this is an example of subaxial cervical spine TB which has been reconstructed anteriorly. Extensive CD junction TB adolescent patient, again it has been done by two stages, first posterior and then anterior. CD junction all anterior has been done, where decompression, reconstruction and fixation has been done. In lumbar spine, try to save the segment because for mobility it is important. The heel lesion, the facts are different. Okay, if there is a neurological risk, there is going to be more risk if you try to correct the heel lesion. So here one has to do religiously the internal gubbectomy. One should try to do the column shortening procedure, which may be in the form of axial procedure, pedicle subtraction, osteotomy or column resection. The anterior column continuity is important, so you must reconstruct the column, and this may be in form of pedicular subtraction osteotomy, where you excise the segment and then you can correct the deformity. There is a case of severe cervicothoracic kyphosis with deficit, and we have to do the VCR, and this column could be corrected nicely, and this bedridden patient started walking again because the compression was significant and there was an instability. The VCR in rigid kyphosis, one has to do the resection of the column, and it is a demanding procedure. One should try to have a controlled distraction and posterior compression and try to correct the deformity, try to correct the apex very nicely, and so you can have a long lasting result. So in conclusion, under proper medical management, proper perioperative planning and meticulous execution of surgical strategy in indicated cases, we can have a long lasting and rewarding result. Management of tuberculosis has been challenging, it is going to be challenging. I think we should pay attention to all these points. I thank you very much for your kind attention.
Very good afternoon, our young budding anesthesiologist. I am here for the pain management part, and I am sure you know that pain actually is an unpleasant sensory and emotional experience which is described in terms of such damage or maybe out of proportion to the damage. So my job has been very much simplified by Professor Srivastav, who spoke at length about your cox spine and many other aspects. So you always have a variety of causes for underlying back pain, and this is where there are few questions I am sure very simple for you to answer rather than any other pain specialist. I am sure you can tell me that when you actually look at the intervertebral disc is composed of all except obviously here it is posterior longitudinal ligament, and you have the least effective way to administer opioids. Well, obviously you will not be using it, but your your colleague anesthesiologist would be using, and this is where you find different routes are there. But then you have the nebulization part, which is actually the least effective one. So this is, and I'm sure many of you would always be writing these gabapentinoids, the gabapentin and pregabalin, and the literature is full of the doses, but please remember it is anywhere from 300 to 3600 milligram upper limit, but then in Indian setup we usually don't use more than 1800 milligram a day. Similarly, for pregabalin, the literature is full of the reports, the dosage varying from 75 to 600, but in Indian setup usually 300 or 450 milligram per day is more than sufficient because of our special genetic makeup compared to the Caucasian race. Well, prevalence of chronic pain, and obviously this is chronic pain including the chronic low back pain, is quite high. And we did a survey where we found that 22% at least of the Indian population is suffering from chronic pain. So you can make out millions and millions of Indians who are actually suffering from chronic pain, including the biggest chunk is actually the chronic back pain. And the International Association for Study of Pain has been focusing on to various aspects. In 2014-15, its focus was on neuropathic pain, because you know one of the important component when back pain is there, you exclude the non-specific pain, but when you're talking of radicular pain, the neuropathic component is bound to be there. Similarly, I'm sure you can answer this question that what percentage of back pain is due to herniated disc, and I'm sure it's coming around 4%. That's the radicular pain we are talking about. Similarly, the other causes of low back pain, you can see here, the lumbar strain or sprain, or you can say non-specific pain comes to around 72%. Disc degeneration comes to around 10%. Herniated disc, we already said 4%. Lumbar canal stenosis anywhere from 2 to 3%, and spondylolisthesis 1 to 2%, something like that. And then spondylolysis 2%. Traumatic case, of course, that can vary from region to region. Malignancy can be there anywhere from 0.5 to 0.7%, and then inflammatory involvement and all those kinds of, they are the least common one. So you know, it was way back, it was the vision of is the vision of Descartes way back in 1644 when he said that there is some hollow tube at the back. So you have a peripheral generator, pain generator. From there it is, the sensation is passing through the hollow tube, and that's how they were able to perceive pain sensation, which is ultimately going right onto the brain. So imagine more than 400 years back he talked like that, you know. And I'm sure, I don't want to bore you with all those neurotransmitters, but you know, various neurotransmitters involved. The moment you put your knife over there, you know, the incision is created, and within 1 millisecond you find that the neurotransmitters are released, anywhere extending from substance P to CGRP to AMPA receptors, all get activated, and then you know there's a release of glutamate and all those kind of things, and which ultimately, you know, if the pain relief is not properly provided during surgery, obviously patient will feel pain, but if optimally controlled, then obviously patient will not feel pain. So an optimum analgesia has to be provided during surgery. Now once the surgery has been done, remember here it's a joint approach between the anesthetist and the surgeon, that yes, patient should be made as comfortable as possible. And you know, that's an essential integral part of the anesthetist who is actually taken up that case. He needs to take the post-op round, day 1, day 2 and all that. And in any case, when you are doing the assessment of pain by NRS scale, numeric rating scale or visual analog scale, ideally the score should be less than 3/10. And if you are not careful enough, not vigilant enough to actually take care of that post-op pain, then you know it may persist. And that results in chronic persistent post-surgical pain, which many times when you follow up those patients at the end of 1 month, 3 months, 6 months, or even 9 months, 12 months, the pain persists. That means that particular period, 72 hours after the surgery, has not been properly taken care of. In addition to that, there may be many other factors, we will be talking about that. So this is where you see the surgery has been done, and obviously an insult has been created, tissue damage is there, and there is a nociceptive input, and finally you find that the pain appears. So this is something which you need to remember. And again, the same thing, kind of peripheral sensitization phenomena is happening over there, where a lot of neurotransmitters are involved, including your sodium channel, potassium channel, ASIC channel, and the release of your 5-HT3. Now over here you find interventions for a patient in pain is based on gate control theory. That's an important aspect. Now what at least you can do here, when you find a patient in pain in the post-operative period, in addition to the medication that has been given, what else you can do without medication? is at least give a back massage. So I'm trying to utilize that area which was painful. If you give a massage, at least some kind of pain relief will be added on to whatever has already been provided. So please remember here, we always follow a 3-step WHO-led regime where you have, minor surgery, moderate surgery, major surgery, you can define it anywhere, and you need to, we go step by step. Paracetamol is a very, meant for mild pain, and then you can add your diclofenac, you can add your, the anesthesiologist, your colleague can give many blocks, blind blocks, ultrasound guided blocks, and then they can also use PCA or patient controlled analgesia in the post-operative period and take care of that. So right now my focus is only the post-operative pain, then I'll move on to chronic pain later on. So a multimodal approach, please remember, that has to be adopted, and this is where you find a multifaceted, because there are multiple sources, always remember, right? Many times during the surgery, minute branches of the nerve get cut and get damaged. So remember here that no single analgesic itself is perfect. You need to use a combination. You need to use a combination of drugs which are acting at multiple receptor sites, and that we'll be talking about. So this is where you find that the post-op pain is, to us it may look very small thing, but then for the patient who actually experiences pain following surgery, following spine surgery or any of those kind of surgery, it is very significant part. He remembers it all throughout his life, and this is where you find that there can be many cortical responses, and then accordingly, these things sum up, and then it persists, and if it persists, it results in chronic persistent post-acute pain. So this is where you find that paracetamol is one entity which is commonly being used. I'm right now talking about the parenteral preparation of paracetamol, which anesthetist is using for post-op pain relief. In addition to that, we tend to use diclofenac injectable, and of course we take the help of some of those COX-2 receptor blockers, and then we are trying to minimize the use of opioid as much as we can, but that doesn't mean that we don't use opioid. Right? Tramadol is a weak opioid but commonly used, and I'm sure you are using it very well, and you are aware of, here I'm talking of parenteral, but then you have a very important combination of tramadol with paracetamol. Tramadol being 37.5 milligram, paracetamol being 325 milligrams. So this combination is very significant US FDA approved synergistic combination. So in your post-op pain, whenever like patient comes for follow-up, nothing like this combination of tramadol with paracetamol. And then of course the anesthetist has been using ketamine. Ketamine has a resurgence, very good for persistent post-surgical pain. You have already been using gabapentin, pregabalin. The anesthetist colleague is using clonidine, and then on top of that they are using their skills to perform various kind of ultrasound guided blocks. This is again just to show you the WHO analgesic ladder. I am sure you can make out that step 1, step 2, step 3 was what I have already talked about. The last step you see, when even step 3 you are failing, that means that is where you need to do and need to perform certain interventions. So please remember that. This is one of the ultrasound guided image of the fascia iliac compartment block. For paucity of time, I can't talk about it in detail. This is where we give femoral and sciatic nerve block depending on the condition, right? These are in addition to the neuraxial block that we perform. And then for post-op pain relief, you see you have a different category. You can give intramuscular analgesic, you can give intravenous. But then if you use PCA, what you're seeing, the yellow line over there where the plasma concentration of the analgesic is very well maintained, that's what we actually need, right? Otherwise there will always be peaks and valleys, which is not good. That means at the peak, you'll find the patient is in pain. When it is down, that means the maximum effect of the analgesic is there. And this is an opioid PCA combination, and those kind of instruments are very much available. This was particular publication. You can see the effect of ketamine as an adjunct to IV PCA. I told you that ketamine, though used for anesthesia, but then a low dose, that means somewhere around 0.35 milligram per kg, is very good for providing an analgesic action. But for that, patient has to be there in something like HDU or ICU under perfect monitoring, multi-para monitors. There has been some recent advances here. Normally you are using morphine, but then recently thing which has come up is liposome encapsulated morphine. It is still under trial. There is another one, bupivacaine, that I'm sure you might have used, the anesthetist is always using. They brought out encapsulated bupivacaine, which can work for about 96 hours, but the cost is exorbitant. So that's what I say, it is right now approved by US FDA only for local infiltration. And my take-home message, very important for you, that at the end of your surgery, I'm sure you can always give local infiltration. Even if you forget anything else, but if you perform a local infiltration at the end of the surgery, around the side where you have put your sutures, that's wonderful, and that's the need of the hour, right? So bupivacaine encapsulated has come, as I said, works for 96 hours, but then the cost is exorbitant. So all these kind of preparations are there. They come out with peripherally acting mu-opioid antagonist also, which, because when we are using opioid, we produce constipation like methyl naltrexone and albumin. This is another one of the publication where they use the, you always have an acute pain service in your setup, and it's an important role performed by acute pain service. If they've done their job very well, you'll find that in your OPD follow-up at 3 months, 6 months, 9 months, the incidence of patients in pain, post-op patients in pain will come down. So as I always said, the massage is another one, but then that's not the only thing. It is simply an important adjunct to your management. It has been used as an adjuvant therapy, use of massage. So what I was talking about, following your spinal surgery, many times the pain persists. And let me tell you that one spine surgery is performed, sometimes then the second surgery is done, then the third surgery is done, and patient still doesn't have relief of pain, what we call as failed back surgery syndrome. So those kind of entities also, just keep it in your mind. It may happen, but we always say a chronic persistent post-surgical pain when pain is persisting even beyond 3 months after the surgery. That's the internationally accepted definition. So acute pain becomes a disease. Remember, WHO has taken up chronic pain as a disease state. It is not simply only pain, it's a disease state. And this is where you find again the knife comes over there, and you have the amalgamation of all those neurotransmitters which are released, including cytokines, interleukin 6 and all those kind of things which are producing peripheral and central sensitization phenomena over there. Alright, but sometimes the patient, even in the preoperative period, may already have CNS sensitization. So remember here, when you have those catastrophizing features, that means the glial activation is already there, the microglia, and these are the patients you need to be very careful. That's why education of our patient as well as education of our surgical colleagues is very important, and they are already very well educated, but then we just want to ensure that the dissection is done step by step in a very fine way, so that we save the damage. We don't produce damage to the smaller nerves. But then you always have genetic predisposition. This is one of the example in the slide. You can see here that some of the pain genes are involved, and you find one of the catechol O-methyltransferase gene is there. Many of the patients, there's always variation from one patient to another. Some of them in the post-op period will require less analgesic, another one will require more. So there can be a kind of epigenetic suppression of GAT6-5 expression which mediates persistent pain. So in those patients you are bound to have chronic persistent post-surgical pain. So this is where I thought again to remind you, you have genetic factor, you have psychosocial factor, as I said, and catastrophizing is very important. Patient is absolutely obsessed. He thinks that when the surgery is done, oh my God, when he comes out of anesthesia, how much pain I'm going to have. So they always ask you these kind of questions. So there is a kind of psychosocial stress over there, and those patients are bound to behave in a bad manner after the surgery. So please remember that. Then the nerve injury and the nerve sparing techniques again, and so proper nerve identification, dissection, and yes, rods and screws. And because many times when the surgeons are putting rods and screws, they are not very sure, because it's not possible that whether that rod or screw is impinging onto the nerve root. Nowadays, latest we have is a 3D kind of screen coming up that can show that your rod or screws are actually compressing onto the nerve. So that is something important, because sometimes in the post-op period you have to remove one of the screws because that is causing a lot of pain. Right, but then already the other thing is that many of the patients who are actually having malignancy at the back may already have received chemotherapy or radiotherapy, and you can have chemotherapy-induced neuropathic pain or radiotherapy-induced neuropathic pain and arthritis obliterans. Right, so these are the important factors which we need to keep in mind. That's why the role of multimodal approach is very important when it's a kind of synergistic. That means 2 plus 2 is not 4, but it becomes 2 plus 2 is 5. That is what you are trying to achieve. Alright, some of the drugs, but then many times you can always refer the patient to, like this particular patient, though she's with the laparotomy, but I've just brought it out, and we have done it for others also, though not for failed back syndrome. This is where your radiofrequency coagulation can be done. And just remember here that if the patient keeps experiencing chronic persistent pain, chronic low back pain. This very beautiful study appeared in 2011, right, that you please remember that there is bound to be a 5 to 11% loss of gray matter, which is actually equivalent to 10 to 20 years of aging. So remember that we need to prevent that, and that you can prevent, by optimal analgesia being provided to the patient. All right. So these are the risk factors. Again, I have already enumerated to you. There is nothing new in this, but yes, genetic predisposition is an important factor, and then primary and secondary, that hyperglycemia is important, because optimum control of blood sugar, especially in diabetics. Many of your patients will be diabetic, when they are undergoing spine surgery. All right. So this is where you find one of the important study here, that you find that you have certain changes on MRI, one of the research study, and when you stop the epidural, you find that the moderate pain appears and there is firing in the central nervous system. And when you switch on your epidural infusion, there is no pain and then there is no firing. These are important studies utilizing PET scans. Alright, and these are the firing things which you can see here, taking up the PET scans. And so the latest evidence on multimodal approach, you can see this appeared in 2019. Ketamine reduces pain and opioid consumption. Similarly, implementation of multimodal approach, you have wonderful results accordingly. So basically, chronic pain is a failure of the sensory, cognitive and emotional homeostasis. Please remember that. And we would like to dedicate this particular talk to Dr. John J. Bonica, an authority who says that chronic pain is a malefic force that imposes severe physical, emotional and economic stresses on the patient. So please remember, because you are dealing with not many of such patients who are with chronic back pain. And as I was telling you, the neuropathic component is bound to be there, not in all patients, in about 33 or 35%. So we define neuropathic pain as a pain arising as a direct consequence of the lesion or disease in the somatosensory system. We have different ways. I don't want to bore you with the assessment of neuropathic pain, because maybe, but just remember that your pain specialist colleague can always do the pain mapping. You can do it, no problem with that. And you can do some of those detailed history everywhere required. Quantitative sensitivity threshold testing is basically more for research purpose. And so moving on to the chronic pain, you have about 60 to 90% who have adults who have experienced back pain at some point or the other. And there may be many causes, but don't forget your osteoporotic fractures without trauma. So please remember that a detailed assessment has to be done. And clues to systemic disease are always there, as Dr. Srivastava already talked about imaging in back pain, so I don't want to repeat, but please remember some of the blocks we perform are either fluoroscopic guided or CT guided, or many times the coronal planes of MRI scans are also utilized. So detailed physical examination important. You can have two types, radicular and non-radicular back pain. You have already excluded non-specific pain. The radicular one obviously is the one which is radiating down the leg, and that you will have because of compression or inflammation, where there is a lot of irritation on the nerve which is coming out of the intervertebral foramen. But then the non-radicular pain is because of facet joint arthropathy, it can be because of SI joint involvement, or it can be because of discogenic pain. Remember, these are three important entities for which is non-radicular pain. Remember here. So that's why detailed neurological examination is required. 98% of disc herniations will commonly involve the level of L4, L5 and L5S1. So please remember, very simple for you to see, there are motor or sensory deficits. L5S1, for L5 there will be weakness of the ankle and the great toe dorsiflexion. Remember here. For S1 there will be decrease in the ankle reflex. For L5S1, sensory loss in the feet. And then straight leg raising test you have already been doing, that 30 degree, 70 degree passive flexion, I am sure you can make out. The Weddell sign for non-organic pain, I am sure can detect a non-organic component to pain. They do not exclude an organic cause, definitely. This dermatomal involvement, this diagram you have to remember by heart. You are finding, like on the dorsum of the feet you will find L5 on the medial side, S1 on the outer side. So these things are very important for you to be able to judge that what dermatomes are getting affected. Right, so Dr. Srivastava has already talked about, so I will not bore you with that, about disc herniation, where there is compression of you can see this, the firing happening at the intervertebral foramen, right, leads on to pain. Various kind of therapies are there. I have already talked about this combination of paracetamol with tramadol, but then you're free to use even muscle relaxants. All those you know better than me, the clozoxazone and many other. And then you want the patient rapid return to normal activities. Your focus is always that. and then sometimes when you fail with the conservative treatment, you resort to performing interventional blocks. There are some alternatives you will see in the market like acupuncture and massage, which are already there, but don't forget, and even our pain specialist should always remember that if there is cauda-equina syndrome, you need to refer the patient to surgery. If you detect malignancy, you need to refer the patient to surgery. So it's referral and then reverse referral. Both kind of things are there. Sciatica and spinal stenosis, again two important things. In spinal stenosis, you are bound to have neurogenic claudication. So please remember, pseudoclaudication, one or both the legs. Remember here. There may be radiation to the buttocks, thighs and lower legs, right? In sciatica you will find that yes, herniated disc and foraminal or spinal stenosis and those kind of radiations are there. This slide shows a conservative treatment on the left side, surgical on the right side. Conservative treatment, moderate bed rest, right? And spinal manipulation and all those kind of medication we already talked about, and the surgical treatment, of course, you know better than me. And most episodes of local back pain are self-limited. Please remember that low back pain is usually due to repeated stress on the lumbar spine, and that's why degeneration may always be there, remember here. So this degeneration, this particular thing, you see something like loss in the height of the vertebral body, and you know the water content goes down. This is where you see the bone on bone kind of phenomena happening, right? And these are the underlying causes. A lot of firing ectopic pacemaker currents are operating in radicular pain, remember, because of central sensitization phenomena. Always remember that one of the important ganglion right at the sacrococcygeal junction, lower down, that's the last autonomic ganglion, and the anesthetist or the pain specialist can always, or you can perform this block, right? That's a ganglion impar or ganglion Walther block. So remember, keep it in mind when patient has chronic persistent perineal pain, nothing like ganglion impar block. You keep getting coccygodynia, those patients, many times people used to do cut the coccyx, but that's not the solution. And even then pain continues. So that's why these kind of blocks, what you can see here, this particular image, the ganglion impar block is there, very nice over there, seen, and that's the ultrasound guided image, because we have been using a lot of ultrasound for performing ganglion impar block and many other blocks. TENS, of course, you all have been using, and in conventional mode or acupuncture like TENS or intense TENS, I can't talk about in detail, but transcutaneous electric nerve stimulation in addition to those conservative or the interventional block can be performed. And it has a counter-irritant effect. It activates your descending pain inhibitory pathway, and activating descending inhibitory pain pathway means you are blocking the incoming noxious stimuli. It's something like applying brakes when the car is moving. So like that. So there are indications for surgery, you know better than me, but remember here, 1 or 2 days of bed rest only if necessary. There is no data on particular exercise. If you ask me, light activity, avoiding heavy lifting, yes, massage is important and more quality research is needed, but there is no evidence that advice to stay active is harmful or for either acute low back pain or sciatica. The role of exercise, many programs are available, but difficult to make any scientific recommendation for any one particular type of exercise. So, and then I'm sure when you have a patient of osteoporosis, you have all these drugs, alendronate, residronate as the first choice, but commonly available is zoledronic acid or denosumab. Like zoledronic acid, we give 4 milligram intravenous infusion over 15-20 minutes when you call the patient once in 3 weeks or once in a month. The another one which is there is teriparatide. This indicated for patients with 2 or more previous vertebral fractures. So please remember these drugs. Then you have bone modifying agents. We already talked about zoledronic acid. You have denosumab, which is another potent bone modifying agent which targets receptor activator of the nuclear factor KB ligand, also approved for skeletal related events. So please remember these drugs. Radiation in pain due to metastatic, and you know it very well that radiation provides pain relief. That's a focused radiotherapy which provides pain relief in about 59 to 70% of patients with metastasis following a malignancy, right? Furthermore, 23 to 34% patients showed no pain after. So it's not a 100% cure, but then still to a certain extent. Muscle loss causing chronic low back pain in the elderly. Remember, when you're dealing with an elderly patient, and then you have the treatment resistance training combined with amino acid containing supplement to prevent any further muscle loss. When you're dealing with patients in 70s, 80s or 90s, that particular age group. And you can always advise for resistance training program, 15 minutes for 2 to 4 times per week for a period of 6 months has given good results. Now, some of the blocks, I'll just take another 2-3 minutes. This is where you find we perform a facet joint block where you are blocking you can see here the Scotty dog. This is oblique image or in the fluoroscopy, and you find that the medial branch of the dorsal ramus is coming over there, and my needle will be targeting the medial branch, eye of the Scotty dog, that's the medial branch of the dorsal ramus. So and you know, you put in a solution targeting this particular area only with about 1.5 to 2 ml. You know, the facet joint is supplied by all your, you know, dorsal branch, you know, this particular medial branch, as well as the autonomic fibers are there, but the capacity is only 1 to 2 ml. It's a zygopophyseal joint, and you please remember that the capsule, when it is lined, so each facet joint can be denervated at least 2 segment level. That means perhaps 3 also for L5S1, both at and above the level of involved. Right, then another modality is radio frequency, as you can see here, CRFA and pulse. One is conventional radio frequency, the other is pulse radio frequency. All right. In conventional radio frequency, we perform, that's the US FDA approved for the management of facet joint arthropathy, where we produce, in addition to giving diagnostic block, remember here, it's a huge challenge, but then when, you know, diagnostic blocks are very important, you know, especially when there is no clinico-radiological correlation. Patient is having back pain, but the image is not showing, the radiological image not showing anything. Or if you have put in your screws and rods, but the adjacent segments are showing degeneration, then again you need to give a diagnostic spinal or the multiple level spinal block. So remember, they are diagnostic block, and then we go on to therapeutic block, and that's where you have the radio frequency denervation. Remember here, this is how the pulse radio frequency ablation happening. And just remember, because I can't explain you everything in detail for paucity of time, the C-phos gene expression is there, and this is where you see the pulse radio frequency, where there is no no denervation as such happening, but it's an electromechanical process. All right, the neuromagnetic field is created. Now if you actually ask me, this is the instrument that we are using for pain management. This is the conventional one. You see at 10 second, 20 second, 30 second, 40 second, 50 second and 60 second the lesion is increasing. So that's approved for facet joint block, remember. Or even for SI joint block I can do, but for SI joint block the latest is cool radio frequency. All right. If I am performing my transforaminal block, remember here, this is the image. You rotate it through 15 degree, and this is where you see the image. You are placing a spinal needle, which is 25 or 23 gauge, and you are going through the sacral foramen. All right. So this is very fine. The transforaminal block you can perform accordingly, and you see we are using the fluoroscopic guidance. All right. And this is the kind of image that you are creating. You remove the probe and then repeat, and this is how we are, finally the image comes over here. And this is where you see the, you can have the repeat steps 5, 1 to 10, and then the final image is there right in front of you. So this is how all the lateral branches, right, we capture, and the L5 dorsal ramus. All right. So lumbar facet denervation can be done, and there is a lot of evidence in favor of that. You can do the translaminar epidural, or you can do transforaminal. The transforaminal one is slightly better than that because it encircles the epidural space, and you don't leave any scope for escape of nerve fibers. All right. I have no time to tell you that what drugs you are using. You can use particulate, non-particulate steroid, you can use methylprednisolone, you can use triamcinolone, you can use dexamethasone, but right now I can't talk about these drugs in detail, and I'm sure you are familiar with that. This is the lumbar radiofrequency facet joint that we are performing, and the transforaminal is usually performed at the 20-degree oblique position. Finally we choose a place and we push in a contrast media, and once we are sure about the image, then we give 20 to 40 milligram of methylprednisolone. Along with that you can give preservative-free lidocaine, right? This is how you see we go for transforaminal lumbar epidural blocks. This is how the final image, you see the AP images, you have seen the lateral images. This is where you see that you have the freedom to perform for the L4, L5, and you can see these images, the selected nerve roots block which are there. All right, the contrast spread you can see, and only when we are satisfied with the contrast spread that we go in for the placement, the precise placement of the steroid, because you got to be very careful when you're pushing in steroid. The last one is SI joint. It may be sacroiliac joint. You push in a patient in the prone position and the needle is advanced, and there are different pictures I'll show you. Ultimately you want the Scouty images, right? And this is how you see, all right. And so SI joint can be blocked, but remember here that if you really ask me, then it is better to do a sacroiliac joint block under CT guidance. All right, you can see here the image, the SI joint, right? This is what you have been seeing, and this is how the precise placement of the needle is there for SI joint block. All right, this is how you see the final image. There is a lot of firing happening upon the SI joint, and you are performing a block. Always remember. The other cases, the surgeon has performed surgery for 2-3 times. There is a lot of epidural fibrosis. Now we are very limited option. We have the technique of percutaneous epidural additionalization, where you perform it and the stainless steel fluoroscope guided spinal the catheter is pushed in, and then you contrast and you see the spread. You see the spread is limited. Then I push in my high lace 10 ml preservative free saline, and along with that 40 mg of methylprednisolone. Catheter is left for 3 days, and the second and third day I am pushing about 10 ml of 0.1 to 5% bupivacaine along with another dose of methylprednisolone, and same way on the third day. So please remember, hypertonic 1 is then utilized. And this is how you see the image with percutaneous epidural additionalization. Now many times you can fail with that also. Then the other option which is left is spinal cord stimulator, and spinal cord stimulator, you know, costs nothing less than 4 to 5 lakhs, but then there is nothing, the cost factor is one and patient's experience of pain is another one. But then everyone can't afford, yes, in India, but then the final US FDA evidence is in favor of when everything else has failed, all blocks have failed, all drugs have failed, then you have this spinal cord stimulation. The results are best for vascular pain and results are best for failed back surgery. The last one is, you know, when your vertebral fracture you are seeing and you need to push in your PMMA cement, polymethyl methacrylate, vertebroplasty is another option, you see, but you need to be very careful. Your needle which you are pushing in should not go too much beyond, but otherwise it can cause compression on spinal cord, remember here. So I don't want to, I mean, like, without wasting any further time, we also have kyphoplasty. You see this image where the cement has been pushed in for vertebroplasty. Again you see the image for the vertebroplasty. Vertebroplasty, again the cement has been pushed in. You see the needle is just not even reached the middle of the vertebra. You see the kyphoplasty is another one where it's a kind of balloon, and only when the balloon is deflated, inflated, deflated, when deflated then you push in the cement. Alright, so all these gadgets are very much available and we are performing it on a regular basis but with precise indication. You can see here the kyphoplasty. The last one is mechanical decompression of the disc, as I told you, and that is where you find that in case you decide for that, you can do your spinal endoscopy procedure, you can have mechanical decompression, nucleoplasties. Alright, there are few gentlemen who have tried using methylene blue for chronic low back pain, imagine, but that's not the thing which we actually want, and it would always be a failure. But then, now in addition to using our needle and doing holistic assessment, remember, patient has suffered from lot of depression. Always remember, there is hypervigilance phenomena. Catastrophizing features are there. So disuse, disability and depression, please don't ignore that. That is where we have to, either we take the help of the psychologist, psychiatrist, or we do it ourselves. We do it ourselves in the pain management, and that's where you actually try to use some of the drugs like less than 60 years. I will using amitriptyline, or if more than 60 years because it causes urinary retention, then I'll try to use escitalopram. Escitalopram is beautiful drug, both antidepressant, and it doesn't have anticholinergic effect, so no retention of urine after 60 years. So that's how we, paucity of time I can't talk about it, but then keep in mind that patient is highly depressed and you have to take care of that also. So basically speaking, you know, chronic pain is a biopsychosocial phenomena, and this biopsychosocial model, let us not forget that everything else has been done. Once some 50% pain relief has been achieved, you can't ignore yoga and meditation. Alright, and again, as I want to re-emphasize, genetic factors do play an important role. There's always gene-environment interaction, and that's what you see here, that we can't ignore that. One patient requires less analgesic, another one will require higher quantity of it. And whatever I've talked about is still the tip of the iceberg. So to conclude, I would like to emphasize that in pain perception, there is a lot of inter-individual variability, multiple biological and psychosocial phenomena are operating. Your take-home message that we need to have a multimodal approach, multifaceted and multidimensional. Your assessment has to be holistic, and don't forget that even if your anesthesiologist colleague doesn't have the skill to perform those blocks, remember here that that's where you can at least do local infiltration at the site of where you have put in your suture, the surgical site. It will do wonders, I can tell you. So it's a unique mosaic phenomena, but I'm sure that in your follow-up OPDs, when you're finding that yes, pain is not getting relieved despite 3 months, 6 months and all that, you still have the time to refer that patient to your pain specialist, and there can always be a reverse cycle where pain specialist is failing. He will always refer the case wherever the surgical indication is needed to your surgical colleague, right? And understanding these mosaics is essentially important to illustrate the nature of biopsychosocial phenomena. Remember, that's what chronic pain is, which will ultimately provide more informed and more personalized pain management. I hope I have been able to simplify my talk. Thanks very much for your kind patience and kind attention, please. Thank you.
Welcome back. I'm happy there are 3 questions. The first question is from Dr. Avinash Kumar from Patna, and he has asked maximum time period to AKT for conservative treatment. First, I would like to little modify your question itself. Dear colleague, you see, whether you operate or you don't operate, you have to continue the AKT whatever the regime you follow. That should be clear. The surgery doesn't make any difference. It is a medical disease. You have to give sensitive antibiotic for adequate period. Now, regarding this adequacy in our country, this regime, it varies from Kashmir to Kanyakumari and from west to east. But it is safe to use AKT for 1 year. Though the trial has been done for 6 months, 9 months, many people they give in for 18 months, okay, but it is safer to give for 1 year. Though still the work is going on, the people they are now trying to do the PET scan and want to see the activity of the disease. So I hope in near future the more clear indication of continuation of AKT or total duration of AKT will be clear. But remember, there are few fallacy even in investigation. Now, a patient has clinically improved significantly, his all symptoms have disappeared, but still in MRI you find little bit of collection here and there. It doesn't mean that the lesion is still active. Okay, it may be a sterile pus. So that doesn't allow you to continue your AKT for 2 years or so. So it is safer to use AKT for 1 year duration. And I think we should try to stick at this moment to 1 year, and that is sufficient. Now, the second question is also asked by Dr. Avinash, and he has asked what is the difference between kyphus and gibbus. Good question, and I think this might be asked also sometime in your exam. The gibbus is a general term. Any hump in the back is labeled as gibbus. When you say kyphus, this is the sagittal plane deformity. Okay, so if a patient is, someone is moving on the road, and even a layman can tell that this patient is having gibbus, there is a bump in the back. But when you say kyphus, you actually referring to the increased sagittal kyphotic, alignment of the spine. Normally, we also have a normal kyphosis in dorsal spine and in the cervical area. So if it is increased, we say it is a kyphotic deformity. When it is a normal, we don't say it is a deformity. So usually we use different terms. One is the knuckle. When one body is destroyed and you have a little prominence of one of the spinous process, you say it is knuckle deformity. When 2 to 3 are involved, you say it is angular deformity. And when you have more involvement and there is an increase in the normal kyphosis, you say it is a kyphotic deformity. I hope I am clear about that. Now, the second question, it has 2 parts. So first part I will be answering, and the second part Professor Saxena will be answering. Dr. Susit from Baroda, actually he has asked what is the management of failed back surgery syndrome. Now, when one operates and even after surgery the patient's symptoms and signs are persisting, then we label it as a failed back syndrome. The most important thing in failed back syndrome is to identify the cause of it, and this is extremely important because the cause may be variable. It may be right from wrong level surgery, inadequate surgery, you have not done the proper decompression, you have put the implant and the screw is touching the nerve root, he started having further symptoms, and there are so many things. Descitis can lead to failed back syndrome, the pseudoarthrosis can lead to failed back syndrome. So first and foremost is to identify the cause of failed back. Once you have identified about your clinical examination and different investigations, then you try to correct it. Sometimes if patient is having persistence of the symptoms, you are not able to pick up a cause, and that is the time you should think, is there is something else? There are so many things. Professor Saxena has talked even the psychological aspect of the pain, and there you must take help of the pain specialist, and I think it is the right time that Professor Saxena will answer the part of it.
Thank you, thank you, Professor Srivastav. I think it's written as management of Feldback syndrome. Yeah, that's right. He's absolutely correct. Your detailed assessment of the underlying cause is very important. Remember here. Now, what he also tried to emphasize is that in addition to MRI, you always have the provision for gadolinium enhanced MRI. You really want to go into the depth at what actually is the reason, underlying reason. All right. And as I was talking about, again, a detailed pain assessment is very important. You also need to have whether there is neuropathic component or no. Right. Patient has the surgery, as I said, done twice or thrice or whatever it is. All right. And the scar at the back, I'm sure, will reveal all those things. So that's the time when initially you can start with conservative treatment. Maybe it is possible that patient has been referred to you and that conservative treatment has already been taken up by another one of your colleagues. But even then, I can always remind you that you always need to start with your gabapentin or pregabalin, any one of them. And remember here, because that's very important, because there's bound to be a nerve compression or compression somewhere over there, or a nerve irritation, remember here, or maybe an inflammation of the nerve, always remember. But so you need to stop that firing happening at the pain generator. Now again, I have not told you that where exactly the pain generator would be located. That is what requires your diagnostic spinal injection, right? But before that, yes, your drugs, the best one, pregabalin, you start always with 75 milligram HS for 2 days. Then from third day you make it BID. Don't make it BID right from day one, otherwise many of them, they stop taking the drugs. You know it very well that sometimes it causes giddiness and body takes time for about 3-4 days to get used to this, because these these alpha to delta ligands, basically initially 3-4 days it's not possible for anyone to sustain that heavy dose, and then gradually you make it you can 75 BID, and then after 4-5 days you can even make it as 75 plus 150, that's 225, or you can make it 150 BID, as I said. So gradually titrated dosage you have to use. If you are more familiar with gabapentin, you can start with, it's always given as three times in a day. Pregabalin twice a day. Pregabalin has a linear pharmacokinetic. Gabapentin has a non-linear pharmacokinetic. So remember that. So similarly, gabapentin will start with 300 milligram and then gradually make it TDS, and then after that means 900 milligram a day. Well, for me, I've seen that gradually we may make it as 2 TDS, that means 1800 milligram a day. Now we don't exceed all these things. Usually pregabalin also I never exceed 300, very rarely for 450 milligram a day. Though as I said, Western literature says 600 milligram for pregabalin. So anyway, so if you are not getting any relief with these two drugs, either of them, you have given and prescribed and you have ensured that patient shows you the empty, because many times they say yes, I have taken the drug, but they don't take it, So the compliance has to be ensured. You see the empty leaflets, and then finally you find that yes, 15 days cross, 4 weeks cross, but the response is not satisfactory, right? Then you go on to your performing your interventions, and that's where I was talking about that if you have one level, spinal level, or 2 spinal level, you can initially go in for transforaminal epidural steroid, and as I said, at the lumbar level, no problem. I'm not talking about cervical level, remember here, because cervical level, remember, the guidelines are not in favor of particulate steroid. Remember here, in the cervical level, if I am using any steroid, it should not be a particulate one. And the particulate steroids are methylprednisolone and triamcinolone, remember here. But I'll rather prefer a non-particulate like dexamethasone. But at the lumbar level, no problem. But even then, that doesn't mean that you liberally use it. But obviously, steroid has to be used. I have given steroid, and then you find, there is 50% relief. Okay, all right, but then the relief is sustained only for about 3 weeks, 4 weeks. Then I repeat another transfer foraminal. So you can repeat 3 times at an interval of 3 to 4 weeks. But even after 3 months I don't find satisfactory result, then yes, it's the time for me to go a higher intervention, and that is where then you go in for your percutaneous additional lysis I had shown in my slide. Right now, percutaneous additional lysis again is a 3 days procedure. It can be 2 days also, but there is a stellated catheter which you push in, right, and initially when and contrast medium you are always using, and obviously it is non-ionic, always remember that. I'm sure you know it very well, the Omnipec and etc. Because with the ionic one, many times the hypersensitive detections are there. So you have used those non-ionic, and then you find that yes, the spread of the contrast is not good, and then you start using your hypertonic saline with your bupivacaine, with your steroid, methylprednisolone mostly, because you know methylprednisolone, the effect may be delayed, but it is more longer sustained. Dexamethasone, the onset is earlier, but then it is short lasting, remember here. So you have tried your percutaneous additional lysis, but then again the results are not good. Then we are left with the last one, if there is no indication for surgery, is for spinal cord stimulation. There again you give a trial. During the trial, if there is 50% pain relief in a period of, you push in this particular stimulator, right? The stimulators are introduced by lateral approach, and then you take it to the level. You remember here, under fluoroscopy, I may take it to T6 or T8 level, so that on stimulation, the stimulation happens in the affected dermatome where the patient is perceiving pain, remember here. Then I leave the catheter for 3 days. In that 72 hours, if I find that there is 50% relief at the end of 72 hours, yes, then I'll go for permanent implantation. Now that's a costly affair. Trial may take, cost about 40-50,000, but the permanent implantation where the pulse generator is ultimately implanted in the wall, in the abdominal wall. So the whole thing goes and crisscrosses from the back to the anti-abdominal wall, and this is all, there's a software, and you do that stimulation. You can adjust it depending on what frequency you want, what amperage you want, and then it can be sustained. Now those spinal cord stimulator may work for 3 years, 5 years, 7 years, like that their life is, and then that's the final one which I can tell you. Though there is also provision for continuous intrathecal pump, but continuous intrathecal pump loaded with morphine or morphine with clonidine or morphine, clonidine and baclofen, they are same costly affair, but then that's mostly used for terminal cancer pain. But here also you have the liberty, but here mostly the FDA approval is for spinal cord stimulation. So that's all I think I can tell you about failed Becton syndrome.
Yeah, there are 2 more questions. The first question is by Dr. Jishan, and I think the question is when to give surgical intervention in port spine. In fact, I have talked in length during my talk that there are 2 situations. Once the patient is not having any neurological deficit, but still you operate. And what are these conditions? Can you recollect again? So these conditions where if patient has instability, the pediatric age group patient, when the spine at rest signs are positive, there is a significant destruction which bound to go into severe kyphosis. So these are the situations where even if there is no neurological deficit, you should operate and stabilize the column. And if patient has significant neurological deficit with bladder ball involvement, you have to intervene early. So this is in nutshell. I will answer your question in this way. Now another question is by Dr. Aditya, and he has asked, MRI suggestive of tuberculosis and clinically suggestive of port spine, but transpedicular biopsy and culture is negative. Can we start anti-tubercular drugs? Now this is a very right and very practical question you have asked, and I must congratulate, and I feel that you have been treating these patients and you are really having this problem. This is a common problem which each clinician is facing. But my answer to this question would be that if you are pretty sure that your collection was all right, your transportation was all right, and still you got the negative report, assure whether the histopathology was sent or not, because sometimes you treat these patients like TB and their tumor. So whether you have sent histopathology or not, that you make sure. The culture for other thing means even fungal infections sometimes it mimics like that. Okay, so ensure that all these things have been done. In spite of doing all these things, still it is negative. There is no harm. I would take the second biopsy. Do it again. Even if after doing all these exercises you find that you are not getting any positive answer, in that case you can start these medications, put the patient under close observation. This is extremely important. You see whether patient is responding or not. Okay, so this is extremely important. So I think I have answered your question. Now the third question is from Dr. Susit Baroda. He has asked role of fentanyl. I think it is for Dr. Saxena.
Yeah. Okay. I don't know. Oh, thanks. Thank you. Well, role of fentanyl. That's what probably is your question. I can again read it. Yeah. Which one is this one? Fentanyl. Yeah. Role of fentanyl. Oh, yeah. That's right. I think you mean transdermal patches. Probably TD. Transdermal patches. It should be TD. I can make out, but I don't know TDF. Nowadays, youngsters use a lot of abbreviation. But so I believe so. You can always message. It should be TDP because transdermal patches, if I'm correct. Because fentanyl can be given intravenously, which I'm sure you will leave it to the anesthetist. Fentanyl can be given by nebulization, again the job of the anesthetist. But patches, yes, you have been using and applying. All right. So this is where it's available in the market in the strength of 25 microgram per hour, 50 microgram per hour. Abroad, of course, also available in 100 microgram per hour, but I think this is enough for us. Now, the point here is, please remember that when you apply transdermal patches for the first time, first you have to be clear about indication. Now, in failed back surgery syndrome, if I have used my oral drugs, I would rather say that okay, to a certain extent you can add patch, this particular one if you are not getting response. But then failed back surgery syndrome, usually the evidence for the role of these patches is very poor. I can tell you very clearly. In failed back surgery syndrome, the evidence is very poor. You can use it, but then you have to use it for lifelong, because ultimately the blocks have to be given in one way or the other, or the surgery has to be again done, whatever it may be. But anyway, I can tell you, as I was telling you about combination of tramadol with acetaminophen. Now that one, tramadol is a weak opioid, but fentanyl is a potent opioid. So when you are using fentanyl, I told you these patches, yes, we have taken a decision somehow. Now you apply it at a point which is not a hairy region, or where the moisture is not there. So you are actually soak the moisture first with your towel and then apply the patch, maybe upper chest or even on the arm, usually upper chest. Now when you apply it for the first time, it takes about 12 hours for the action to start. Always remember, okay, first time when you have applied. So you have taken a decision. If it is pain score is just 4 by 10 or 5 by 10, you may start 25 microgram per hour. But if it is around 6 by 10, 7 by 10, 8 by 10, I'm saying these are the visual analog scale scoring, then yes, you have to start with 50 microgram per hour. And as I said, they work for 72 hours. That means 3 days. So at the end of the 72 hours, you have to change the patch. All right. So you change the patch and you apply another one. But take precautions because there has to be proper disposal of these patches. Always remember. But then also keep in mind that you got to monitor for the side effects of fentanyl. Remember, and don't forget, one is respiratory depression. Right? Very rarely happens, but you've got to monitor. Nausea and vomiting may be quite high in many patients. You've got to use antiemetics. And the third one is pruritus. Patient starts having itching. So you may have to use levocetirizine again. And the fourth one is constipation. So these 4 important side effects of opioid have to be kept in mind. And then you can at the end of third day, then every 72 hours you keep applying these patches. If the response is inadequate, you can use 50 plus 25. 75 is usually, for Indians, it is usually on the higher side, usually 50 microgram, okay. But then if patient says, what the hell that I'm changing it every third day, then you have another option available which is known as buprenorphine patch, right. Buprenorphine works for a longer period, that patch works for 7 days. There you have to change it at the end of the 7th day, and that comes in strengths of 5 milligram or 10 milligram or 20 milligram, all right. So there, depending on that, if the pain is too severe, I may start with 10 or 20, but if it is mild, then 5 milligram per hour. And there you change the patch at the end of the 7th day. So there the compliance is very good, but then both the things are there. You have the option of either using fentanyl patch or using transdermal buprenorphine patch. Abroad you also have other patches like transdermal ketamine patch, transdermal clonidine patch, but right now in Indian setup we have these two patches. I hope it suffices. Right.
There is another question from Dr. Vaibhav, and I think he has asked, please define internal gibbous. So if there is an abnormal kyphotic angulation in the anterior column of the spine and it is abutting the neural structure, then we say it is internal gibbous. There is another question from Dr. Abhinash, and he has asked about, is there any role of flupyritin in management of spinal condition?
Okay, right. Not very good results with that. Not very good results with that in the management of spinal condition. Let me tell you, there are at least 20 analgesics in the market. You start from diclofenac, you go on to etoricoxib, and then in between you have flupyritin, and there are many other drugs which are there, even nefopam for that matter. But I'll tell you, yes, etoricoxib, yes, definitely you don't have those side effects which are there because of diclofenac. But whichever you are starting, please remember that the kidney function should always be assessed right in the beginning. What's the blood urea, what's the serum creatinine, LFTs, KFTs must be done, right? And then you got to repeat these LFT, KFT every 3rd month, remember. And you got to be very careful in diabetics, and in geriatric patients you got to be very careful. So I won't say that I would rate flupyritin better than, yeah, to a certain extent it's better than diclofenac, little bit better, but then I would say etoricoxib is still one where we have the minimal side effects. So you're most welcome, but then the evidence is lacking in favor of flupyritin in spinal conditions.
So thanks, colleague. I think we
Thank
have
you so
tried
much,
to sort out your questions, and our best wishes for your clinical practice and exam.
Yeah, best
Thank
of
you
luck.
very much.
Best of luck for the exam.